Good morning, everyone. My name is John Ring, and as Janie said, I am the immunization representative for the Virginia chapter of the American Academy of Pediatrics. I'd like to welcome all of you on this early morning to a special grand rounds presented through the AAP's Visiting Immunization Expert Initiative. It is a partnership production between the American Academy of Pediatrics, the chapter, and most importantly, your institution, the Carilion Children's Hospital and Clinic. As the chapter immunization representative, I became aware of the Visiting Immunization Expert Program about a year ago. Many of you here may be unfamiliar with it, as I was. In 2019, the National Academy established a project entitled Supporting Pediatricians to Increase HPV and Pediatric Influenza Vaccination Rates. This project recognizes two things: that immunizations are a key function for all pediatricians, and that uptake of these two vaccines in particular could be improved. In order to achieve its stated goal, the project focuses on developing and then applying the Academy's evidence-based educational resources, its organizational skills, and informed best practices. The Visiting Immunization Expert is a key part of this project. It brings together recognized immunization experts with institutions that own the project's goal as their own. Institutions like yours, the Carilion Children's Hospital and Clinic, institutions that want to serve their patient populations, often children who are disadvantaged, as effectively as possible. Today's event, as you can imagine, has been a long time in planning. The Virginia chapter participated in a competitive application process back in January. Our application reflected the value we place on immunizations, our commitment to evidence-based practices, and recognized the diversity of the Commonwealth, its geography, economy, race, ethnicity, and models of care provision. Attention was also paid to trainee education and breadth of reach. That sounds like you, doesn't it? In the past, the initiative has been implemented in person, but the pandemic changed all of that. Regardless, we are confident that today's presentation will be of great value. We anticipate that attendees will find the content to be informative, practical, and actionable. We think that today's presentation will benefit the expert, the provider, and the trainees in attendance, and most importantly, the patients that we all serve. It's my pleasure now to introduce this morning's visiting expert, Dr. Michelle Hoffman. Dr. Hoffman graduated from the University of Rochester, where she minored in American Sign Language. So, Janie, I guess that means that if the WebEx audio feed fails, we're still in good hands. She subsequently earned her MD degree at the University of Chicago. Dr. Hoffman completed a pediatrics residency at the University of Nebraska, where she served as chief resident. She then completed a fellowship in pediatric infectious diseases at the same institution. Dr. Hoffman currently practices her subspecialty at Golisano Children's Hospital of Southwest Florida. She is board certified in general pediatrics and in pediatric infectious diseases. Dr. Hoffman has been an active member of the American Academy of Pediatrics since her residency days. She is also a member of the following professional organizations that are pertinent to today's presentation: the Pediatric Infectious Diseases Society, the Infectious Diseases Society of America, and the Society of Healthcare Epidemiology of America. Dr. Hoffman is an energetic and effective advocate for the importance of childhood immunizations. Of note is that she has a particular interest in combating the anti-vaccination movement. And given that anti-vaxxers are linking their targeted disinformation campaigns to understandable concerns about the novel coronavirus vaccine, Her expertise is even more pertinent during these pandemic times. Dr. Hoffman is a skillful proponent of HPV immunization, giving her a skill set very applicable to seasonal influenza immunization in pediatric patients. So please join with me in welcoming Dr. Hoffman to Carilion Children's Hospital and Clinic.
Good morning, everyone. So today we are going to talk about influenza vaccines. I have no disclosures. My slide was the one previous, but I'm having trouble backing up here. So I'm just going to move forward. All right, so our objectives today. We're going to review briefly the science of influenza vaccines and the recommendations made for the 2020-2021 season. Then we will summarize the language to promote influenza vaccination for the whole family. We will address barriers to influenza vaccine update and talk about vaccine hesitancy and how to approach that. And then finally, we'll talk about the impact of the COVID-19 pandemic on influenza seasonal vaccines and the season itself. So vaccine science. Some common questions about influenza vaccines that I often get are, why do we have to give these annually, and why isn't there a universal influenza vaccine? So we're briefly going to talk about the science that supports why that is. All right, so here is the influenza virus, and the influenza virus has on it two main surface glycoproteins, one being neuraminidase and one being hemagglutinin. Hemagglutinins' job is to attach the virus to the cell, and neuraminidase then cleaves the virus from the cell, releasing virions out to infect more cells. All right, so influenza virus has significant variation from year to year, and then at times can also cause pandemics. So epidemic influenza occurs to a large number of people in a community, and this occurs in both influenza A, influenza B, and this is what is caused by antigenic drift. And so basically, the way we get drift in influenza is that there are point mutations in those surface glycoproteins, the hemagglutinin and the neuraminidase, and those change from year to year. And so it is the job of the World Health Organization and a global community to help us decide which influenza A and influenza B strains will circulate each year and help us make our vaccines. When we talk about pandemic influenza, that's basically an epidemic that spreads across countries and continents. And this happens solely in influenza A, which varies its subtypes based on the hemagglutinin and the neuraminidase, and those can actually undergo whole gene segment recombination, leading to antigenic shift. And this will happen in either the hemagglutinin, the neuraminidase, or both. One way this happens, this antigenic shift happens, is when influenza virus in an animal population actually gains the ability to infect humans, such as in swine flu or avian flu. And it leads to this novel subtype of the virus, such as H1N1, which you all may recall from several years ago. All right, so this is just a graphic that shows the difference between drift and shift and how pandemics occur. As you can see here, in antigenic drift, you have point mutations, whereas in antigenic shift, you see large portions of the gene or gene segments that are altered, and that's what leads to pandemics. So there are three major influenza vaccine types. There's the inactivated influenza vaccine, And usually there are 3 or 4 candidate vaccine viruses that the World Health Organization chooses based on the circulating virus in the opposite hemisphere. So for us, that would be the southern hemisphere, about 6 months prior to the influenza season. And the way in which these are made is that those candidate vaccine viruses that are chosen, they're grown in either chicken eggs, which is the egg-based process, or in a cellular-based process, which is a newer technology, in these maiden-Darby canine kidney cells. And this invokes a humoral immune response in people who receive the vaccine. So then there is the recombinant influenza vaccine, and that uses the hemagglutinin protein from the candidate vaccine virus, and it is grown in a completely egg-free system. Finally, we do have the live attenuated influenza vaccine, or LAIV, and that is a cold-adapted attenuated virus that is made to replicate only in the respiratory tract. The advantage of this vaccine is that it induces both humoral and cellular immune response, which is somewhat more robust. This is a graphic showing you the difference between the traditional egg-based vaccine production and the newer technology of cell-based production. And it's important to note that in egg-based production, we have trouble with mutations that can occur in the hemagglutinin head region, and that can reduce the efficacy of the vaccine-generated antibody responses to circulating viruses, particularly in the H3N2 component of the vaccine in several recent years. So that has what has decreased the effectiveness of our vaccines in recent years. The cell-based process does not tend to have that variability and mutation in that hemagglutinin, and so it tends to preserve and match better the candidate vaccine viruses when it is produced. So we have these universal influenza vaccine questions. So why don't we have one that works every year? And the main reason is that antigenic shift that occurs from year to year in those hemagglutinins and neuraminases. And there are several ways in which you could circumvent that, but there are challenges to those. So instead of using that head region of the hemagglutinin, you could target the stem region of hemagglutinin or other conserved regions of the neuraminidase and the hemagglutinin proteins. There's also a matrix protein 2 directed responses to influenza. However, those are not as immunogenic as the hemagglutinin, and so it's hard to produce a robust vaccine response to those, but they are conserved across all influenza viruses, and so they can be more cross-protective. We're not going to dwell on this, but this is some of the challenges, and you can review this slide at your leisure. So let's talk about the influenza vaccine recommendations for this year. Notably, last year, there were 188 reported pediatric flu deaths. And what's important to note about that is that it matches the highest recorded number of pediatric flu deaths during a regular flu season, which was during the 2017-2018 season. Of the 175 deaths in the 2019-2020 season, 43.4% of the patients had a pre-existing medical condition, and nearly 2/3 of those who died died due to influenza B. In 2017-2018, approximately 1/3 of the deaths were in otherwise healthy children, and among pediatric deaths in kids 6 months and older who were eligible for vaccines, 80% had not received an influenza vaccine during that season. And so that's really important. Why aren't kids getting these vaccines, especially those who are more vulnerable? So this looks at influenza vaccination coverage in the United States in children 6 months to 17 years between 2010 and 2019. And coverage, basically, as you can see there, overall is about 63%, and it has slowly increased over time. But we are certainly not getting a robust number of children vaccinated. The greatest number that are vaccinated tend to be between 6 months and 4 years of age. And some of that is likely due to the fact that they have more contact with their pediatricians and therefore have more discussion with their pediatricians about the influenza vaccine on a regular basis. Plus, they're also getting their routine vaccines, and kind of bundling those can be an effective strategy. So we know that children will have the highest attack rates of influenza, and they play a major role in transmission to household and other close contacts. And children under 5 years of age, especially those less than 2 years of age, as well as those with underlying medical conditions, are at increased risk of hospitalization and complications from influenza. So the recommendations for 2020-21 is that we give influenza vaccines to all children and youth ages 6 months and older. And the emphasis especially is on those high-risk groups, as well as their household contacts and caregivers. This is just the graphic from the recommendations from the AAP and ACIP that describes whether or not you need 2 doses versus 1 dose of influenza vaccine. And you can refer to that if you have questions about that. So the types of influenza vaccines that are available this season include the quadrivalent inactivated influenza vaccine, the live attenuated vaccine, and then the cell culture-based inactivated vaccine that is made without the use of influenza virus or eggs. And notably this year, we have a change in the formulation of most of the quadrivalent vaccines, with the exception of the Afluria quadrivalent vaccine, in that those that are 6 to 35 months are being given a 0.5 milliliter dose instead of the 0.25 milliliter dose that has previously been given. So we give the exact same amount to ages 6 to 35 months as we do those greater than 3 years of age. Notably, the AAP has no preference for one product over another. So contraindications for influenza vaccines. Basically, anaphylaxis is the only major contraindication for inactivated influenza vaccine. When it comes to the live attenuated vaccine, there are some other contraindications, including kids less than 2, those between 2 and 4 years of age with asthma and wheezing, those with cochlear implants, immunosuppressed or asplenic patients, those who have had a live virus vaccine within 4 weeks, and those who have been on an antiviral for influenza, as well as up to 2 weeks after stopping that antiviral. In addition, those on aspirin and those who are pregnant are contraindicated to get the live attenuated vaccine. There are some precautions. So this is where the pediatrician or your pediatric infectious disease physician may weigh in on whether or not these children should get the vaccine. Those with a history of Guillain-Barre, there is some literature about a possible association with Guillain-Barre, and I will address that a little later in our talk. And then for the live attenuated vaccine, there is precautions noted for kids with asthma greater than or equal to 5 years of age, as well as those with diabetes, chronic disorders, and metabolic disease. So important things to note. Things that are not a contraindication: minor illness with or without fever. So a kid comes in with a stuffy nose, and that is not a contraindication to getting the vaccine. And those with an egg allergy, also, this is not a contraindication. It has not been found that influenza vaccines either those made using eggs or the cell-based vaccine really cause a significant amount of allergy in those who are, quote, egg allergic. You may defer the influenza vaccine to clinical judgment if you have a moderate to severe febrile illness. And really, the question there is the patient going to come back to care to get that influenza vaccine? And if they're not, you do not necessarily have to withhold the vaccine, even with a febrile illness. And then it is important to note, especially this year, that we need to defer the influenza vaccine if a patient currently has COVID-19 infection until it's resolved and until the quarantine period has elapsed, or the isolation period has elapsed. And it's also important to note that you need to defer the nasal vaccine, the intranasal vaccine, if someone has significant nasal congestion, because that can impede the delivery of the live attenuated vaccine intranasally. So let's talk about promoting influenza vaccines. Why should you give them to your patient? They are safe and they help prevent severe influenza illness and complications. They prevent influenza-related deaths in children, and there is data to prove that. They also will cocoon vulnerable people around them, including grandparents and parents who might be more vulnerable than the children. And then it helps keep kids from missing school and parents from missing work due to influenza illness, and it can decrease the burden on the healthcare system, which is an important note, especially during this COVID-19 pandemic. So, efficacy of influenza vaccine. This is based on prevention of laboratory confirmed, medically attended cases of influenza. And efficacy, therefore, underestimates the impact of the decreased or underestimates the impact of giving the influenza vaccine, which can decrease missed school or work, decrease doctor's visits, hospitalizations, and ICU admissions, as well as decreasing transmission to others. So when we look at efficacy and compare it to effectiveness, efficacy is measured in a randomized controlled trial, and it's under optimal conditions. And usually the participants are healthy. The effectiveness of a vaccine can be measured in an observational type study. And this will include patients with underlying medical conditions and the vaccines being given under real world conditions. This is just one example of a study by Chung and others in the journal Pediatrics in 2019, looking at the adjusted vaccine effectiveness by influenza type and subtype for kids 2 to 17 years of age receiving either the inactivated or the live vaccine between 2013 and 2014 versus 2015 to 2016 seasons. And as you can see there's varying effectiveness. And again, the effect, especially the lower effectiveness is H3N2 population, that is likely due to vaccine, not exactly mismatch, but when it's produced in that cell-based, egg-based line, you can get variation and mutation in that hemagglutinin portion, and that can lead to a vaccine mismatch with the circulating influenza virus. As you can see, the effectiveness varies from 7% to 67%. Know that flu vaccine will prevent pediatric deaths. And of 200, in this study that looked at influenza vaccine effectiveness against pediatric deaths between 2010 and 2014, 291 deaths in patients with a known vaccine status, only 26% had the vaccine before illness onset. And it was noted that of deaths in children with high-risk medical conditions, only 31% were vaccinated. So the vaccine effectiveness noted against death was 65%, and in high-risk conditions was 51%. So let's talk briefly about cocooning, which is immunizing people in close contact to those patients who are susceptible to an illness but cannot be vaccinated due to any number of medical contraindications or being too young to have a vaccination. And so this is especially important in households with newborns, as well as with elderly family members, such as grandparents. So this is basically a review of who is at high risk for influenza complications. And as you can see, there are numerous groups that are at high risk. I'm not going to read through all of them. Those children less than 5, especially those less than 2, is an important cohort that we really need to focus on vaccinating. There's also evidence that we can protect infants by giving moms flu vaccines. So in this study, in the recommendations for this year, 2020-2021, infants were noted to have that they can have a risk reduction up to 72% for laboratory confirmed influenza hospitalization in the first few months of life if moms are vaccinated against influenza. And pregnant women who are vaccinated provide their babies protection against influenza through passive maternal antibodies, and breastfeeding can also protect babies and help boost the immune response to influenza. Sorry, I'm stumbling a bit over my words this morning. How can you make flu vaccines more accessible? So the National Vaccine Advisory Committee #1 standard is that vaccination services should be readily available. So one of the ways you can do that is by creating vaccine-only appointments or dedicating certain office hours to vaccination. In addition, having the ability to vaccinate siblings or other family members at the same well-child visit can really increase the uptake in influenza vaccination. You need to obviously ensure proper storage and handling practices so that your vaccines are readily available and that they are all efficacious at the time that you're giving them. And then if there is a vaccine shortage, you need to know where to refer patients, such as a public health service or other practice, if you do not have vaccines available in your own practice. Next, I want to talk about vaccine hesitancy, which is a behavior influenced by a number of factors, including issues of confidence, complacency, and convenience. And it's really this heterogeneous group of people with varying degrees of indecision about vaccines and varying degrees of education and knowledge about vaccines. So when we categorize parental attitudes towards vaccines, we can kind of put parents in different subtypes. This study looked at parents and kind of categorized them into different groups and looked at the percentage of parents in each group. And so the first parent type is an immunization advocate. And that's a person that's going to strongly agree that vaccines are safe and needed. And that group was 33%. And then there are the parents that go along to get along, meaning they don't question vaccines and they tend to lack knowledge about them, but they believe that their physician recommending them is sufficient enough to go along and give the vaccine. And that's 26% of the parents in this group. And so there you have 59% of people tend to get the vaccine and are less likely to refuse. And then you have the health advocate. So these folks can agree that vaccines are necessary, but are less sure about their safety, so they may lie on the fence. Whereas the fence sitter has significant concerns, is knowledgeable about vaccines, and may vaccinate, may delay, or may actually refuse vaccines. And then you have the refuser that has distrust, safety concerns, religious beliefs, or other reasons for refusing outright. This study was back in 2005, and I would venture if we re-surveyed folks, parents, we may have a larger number of people on those fence sitter and refuser percentages. So looking at the evolution of a vaccine program, basically you have, as with COVID, let's say, you have pre-vaccine era where there's a disease, then you make a vaccine and you get vaccine coverage and the disease decreases. In addition, as vaccines are given, you get adverse events from the vaccines, and the combination of decreased disease and increased adverse events can lead to a loss of confidence in the vaccine, and so a decrease in the number of people getting that vaccine, and then you can end up with an outbreak. After an outbreak, often there might be some resumption of confidence and need for that vaccine, or interest in that vaccine, and so you may again get increased uptake in the vaccine, and then ultimately the goal would be eradication of a disease. We all know that this isn't exactly how it goes, however. So influenza vaccine hesitancy has been designated as one of the 10 leading threats to global health by the World Health Organization, and about 1 in 15 United States parents are hesitant about childhood vaccines. So that's routine childhood vaccines. Interestingly, greater than 1 in 4 parents are hesitant about the influenza vaccine. So there's a large discrepancy there. 70% of parents strongly agreed routine childhood vaccines were effective versus only 26% agreeing influenza vaccines were effective. So this is the area that we really need to target. This is a look at a survey that was done, and this is a vaccine hesitancy score for the influenza vaccine compared with childhood vaccinations. And what I really want you to see is this top line in each of these bars is representative of all childhood vaccines, and the line below is representative of influenza vaccines. And for example, this statement is, I do what my child's healthcare provider recommends about vaccines, and strongly agree was 56%, whereas when it comes to the flu vaccine, it was 40%. The only thing that really matched between childhood vaccines and influenza vaccines was people being concerned about side effects, serious side effects of childhood vaccines and influenza vaccines, and those were equal. So here, getting vaccines is a good way to prevent or to protect my child from disease versus getting a vaccine is a good way to protect my child from influenza. 73% strongly agreed for routine vaccinations versus only 38% for influenza. So these are some reasons that parents may give for not getting the flu shot. First of all, I just never get around to it. Second, the flu shot is unsafe. They're worried about things like thimerosal or Guillain-Barre Syndrome. My kids never get influenza. The flu shot made me or my child sick. The flu shot doesn't work. My child still got influenza, so why give it to them this year? Influenza isn't that bad of an illness. It's like a cold. And this year, certainly we have the concern that COVID-19 brings in about fears about going to the doctor's office and catching something else. So ways to address influenza vaccine hesitancy include, first of all, starting with a standard approach to addressing vaccines in your practice. You want to present the flu shot as part of a normal well visit. So instead of saying, would you like the flu vaccine today? You say, today your child is due for the flu vaccine. So make it a statement, make it a thing that we expect to happen. And also personalizing the message can really make a difference. For a physician to say, I know a child that was hospitalized and has now chronic lung disease or who even died from influenza personally, that can really hit home with parents. So there are different methods to approach vaccine hesitancy, and this is just one mnemonic that people can use. So the announce, inquire, mirror, secure mnemonic talks about announcing that the vaccination will happen and assume that the patient is ready to be vaccinated or the parents are ready to have their child vaccinated. Inquire, so you want to use open-ended questions to understand parents' concerns. And then mirror, you want to reflect back what you have understood to make that person feel heard. So I understand that you're really worried about the safety of the influenza vaccine and the contents of the vaccine, and then talking about that by consolidating and securing trust. Another mnemonic is the ask mnemonic, where you acknowledge, steer the conversation, and then know your facts. So it's really important to go in prepared and confident about influenza vaccine facts. There's this great handbook, the vaccine handbook, which is available online and has all of this information in terms of how you can combat vaccine hesitancy in general. So the next thing, let's talk about why parents think the flu shot is unsafe. So vaccine safety, we need to explain to parents that flu vaccines are thoroughly tested, that their safety is actively monitored after licensure, and over 150 million doses are safely given each year. And this just goes through the different trials and all of the things that happen pre-licensure and post-licensure of a vaccine. Concerns about Guillain-Barre syndrome. So there's variable data ranges season to season of Guillain-Barre syndrome and its association with influenza vaccine, but it has been found that 1 to 2 additional Guillain-Barre syndrome cases per million flu vaccine doses administered did occur during one season. And overall, though, it is noted that it is more likely a person will get Guillain-Barre syndrome following influenza illness than after vaccination. And so really it's about those worse influenza seasons where you see increased Guillain-Barre syndrome. And then there's this concern for thimerosal, and we know that single-dose vials used in infant influenza vaccination contain no mercury, so there is no concern for that. Next, my kids never get influenza. So no one can ever predict who will get the flu in the future. And vaccination is the #1 most important thing you can do to prevent influenza. And knowing it's not just about influenza deaths. For every death, there are many, many more hospitalizations and even more illnesses. And those illnesses have their own burden of keeping kids out of school and parents out of work. The flu shot made me or my child sick, and we all know that that is just not true. So first of all, it's important to note that all flu-like illnesses are not influenza, and that injected vaccine does not contain viable virus, so it does not make you sick. The live attenuated vaccine is attenuated and only replicates in the nose, and it is shown not to make you sick with influenza virus. The mild side effects you experience after influenza vaccine, like low-grade fever, are not flu. And when people do get sick after getting the vaccine, the likelihood is that they were exposed to the virus prior to that 2-week period of developing immunity, or during that period of developing immunity to the virus. The flu shot doesn't work. My child still got ill with flu. So we know that the influenza vaccine is not 100% effective at preventing flu. And that's not what we should emphasize with this vaccine. It's a bit different than what we emphasize with, let's say, the MMR vaccine at preventing measles, mumps, and rubella. It decreases serious illness, and that's really important. It decreases the likelihood of complications from influenza, hospitalizations from influenza, and the likelihood of death in children, including those without predisposing conditions, perfectly healthy children. So it's not that you're getting it to completely prevent flu, but your flu will be an attenuated illness, not as severe. Influenza is not that bad. Again, not all flu-like illnesses are true influenza. It is not just a cold generally, and it has much more increased complications than, say, rhinovirus. A mild illness can still lead to missed school or work, and we know it can lead to hospitalization, ICU stays, intubation, secondary bacterial infections, and even death in healthy children. And then COVID-19 fears. So it's going to be important this year to emphasize the infection prevention practices in your office, like masking, screening patients, keeping sick versus well children away from each other, and the importance of well child care despite the pandemic in order to prevent other diseases, to encourage people to come to care and to get the influenza vaccine. So finally, let's talk about COVID-19. So we know that at the beginning of the COVID-19 pandemic, there was decreased immunization rates. This is data from the Vaccines for Children program provider, Vaccines for Children program, and it talks about provider orders for vaccines and doses administered for routine pediatric vaccines. So when we declared national emergency for pandemic COVID-19, the drop-off of non-influenza doses of vaccines for children vaccines sharply dropped. And this talks about measles containing doses. So this isn't specific to influenza vaccines. This is about other vaccines. And so kids were less likely in general to get vaccinated against any childhood illness. We also know that COVID-19 at the beginning of the pandemic had an impact on influenza activity. So there was decreased flu activity during the beginning of the pandemic. And at that time, the flu season was just starting in the Southern Hemisphere. You can see here, first of all, looking at the United States in the 2016-2017 versus the 2019-2020 season, the dotted lines show you influenza activity or positive specimens went way further out in the season. And then here, when the national COVID emergency was declared, the solid line shows you that we had a sharp drop off in positive tests for influenza. And that had to do with keeping people at home and not having the large spread of influenza at that time. Then in the Southern Hemisphere, if you look at their line for the 2020 season versus the 2019 season, this is the 2019 season positive tests. And this line down here, right against this x-axis, is the line for the 2020 season. So there was barely any influenza. The number of influenza cases decreased by 98% in the Southern Hemisphere. So anticipated differences for the US 2020-21 flu season include that there's regional variation in COVID-19 prevention measures. And so there will be variation in influenza circulating. And we're seeing now that that isn't quite as prominent. The rates of vaccine uptake are certainly different this year than they were for influenza other years. And the effectiveness of this year's influenza vaccine could have an impact if we had more circulating influenza. And then the fact that we have the co-circulation of the SARS-CoV-2 virus is important. So let's look at the weekly cumulative doses of influenza vaccine distributed in the United States from 2016 to 2021. And as you can see, we had an increase in influenza vaccines distributed this year compared to previous years. When you look at children, however, there is not a large increase in the percent vaccinated. This dark line is the percent vaccinated in 2020, 2021, and the yellow lines are those in 2019, 2020 for influenza vaccines. Looking here at the weekly cumulative influenza vaccination coverage by race ethnicity, you can see that in the 2019-2020 season, we had greater number of Black non-Hispanic patients, children, vaccinated against influenza versus this year. And otherwise, relatively similar rates in other ethnicities. So that disparity there is very striking. So this looks at the weekly national summary for the 2020, 2021, and selected previous seasons. And it shows you that for the, where is my 2020? Here's our 2020, 2021 season. This is the percent of visits for influenza-like illnesses. And it's just strikingly lower this year. Oh, these are back. Yes, this is correct. Okay. So in 2019, 2020, the week ending December 21st, 2019, we didn't have data over the Christmas and New Year's holidays, so I didn't have a more recent photo. This was the surveillance of influenza-like illnesses across the United States. And you can see a lot of states, including those in your area, with high or very high influenza activity. This is this year. So we really haven't even gotten out of the minimal to low categories. So I thought this article was interesting. This looks back in 2010, talking about can we reduce the spread of influenza in schools with face masks? And indeed, they did find that there was a trend toward mask wearing, resulting in a significant reduction in the mechanism for limiting a significant self-perpetuating reduction mechanism for limiting influenza transmission in schools during a pandemic. And we know that now, obviously, that we're wearing masks and socially distancing, that our rates are lower. So the problem this year is that there's a large overlap in symptoms between COVID-19 and influenza. And the main difference in those two is the loss of taste or smell. The other major differences between influenza and COVID-19, though they're difficult to tell apart, is that COVID-19 in general, about 5 days from exposure to being symptomatic, whereas influenza is a bit shorter, that it only takes about 1 to 4 days. In addition, the amount of time you're considered contagious is a bit longer for COVID. We obviously have antiviral treatment and a preventative vaccine that we have used many, many years past for influenza, whereas at the beginning of this fall or the influenza season, we did not have a FDA-approved COVID-19 treatment, and the vaccine was not yet available. All we had was self-isolation. And then the case fatality rate, as we know, is greater for COVID-19. So it's important to note, should you give the influenza vaccine to someone with COVID-19, active COVID-19? And the CDC says that the vaccination should be deferred or postponed for people with suspected or confirmed COVID-19, regardless of whether they have symptoms, until they have met criteria to discontinue their isolation. Just so following those isolation guidelines and then bringing the patient back in for an influenza vaccine. So interestingly, a paper that came out, in August or so, looked at the decision to vaccinate against flu during the pandemic. And this flowchart basically talks about the child and their caregivers and their decisions to vaccinate their own children and themselves against influenza last year versus this year. And so about 54% of the respondents stated they intended to vaccinate their children against influenza in the coming 12 months. And that was an increase by 15.9% compared to those that reported an influenza vaccine for their child in the previous 12 months. And in addition, about 58% of respondents stated they plan to obtain the vaccine for themselves this coming influenza season. So this was done prior to our current influenza season. If we look at a comparison between caregivers who plan to vaccinate their children and those who did not plan to vaccinate, the greatest likelihood of planning to vaccinate your child in the next year was correlated with if the caregiver planned to vaccinate themselves And they were also more likely to immunize if they had an education beyond high school, and if the child had a chronic illness or took medications regularly, or if their other vaccines were up to date. Finally, they looked at factors associated with caregivers who did not vaccinate their child against influenza in the past 12 months, but then who did plan to have their child immunized this year. And this showed that the following factors predicted a willingness to change from not vaccinating to vaccinating, and those were their children were up to date with their other non-influenza vaccines, their regular childhood vaccines. Caregivers received the influenza vaccine last year, so the parent received it last year. Or caregivers who were worried that their child actually had COVID-19. This was performed in an emergency department, the questionnaire. And so those who actually had or were thought to have had COVID-19 while they were being asked these questions were more likely to vaccinate their children this year if they hadn't done it the year prior. So ultimately, these are the predictors of caregivers who didn't vaccinate their child for their child to receive a flu vaccine next year, identified by this multivariate logistic regression analysis. And really, the big difference was those caregivers with higher education and those caregivers whose vaccinations were already up to date, as well as caregivers who had their own flu vaccine last year, and those that worried about the child having COVID-19. So this year, our approach to influenza-like illnesses includes an approach to COVID illness. And so we need to test both for influenza and COVID-19. If a patient is in a high-risk group and it's within 48 hours of symptom onset, and you know that there is some influenza circulating in your community, at that time you might consider starting an influenza antiviral. And it's important to isolate per the COVID-19 recommendations, regardless of if you have a positive flu or negative COVID-19, because we do have some false negatives, especially when talking about the antigen test for COVID-19, the direct or the point of care testing. And we need to be aware of potential for co-infection. So I'm going to conclude. There is some great information on the AAPU website about immunization, advocacy, dealing with families that are hesitant for vaccines, and lots of information on influenza vaccines, as well as HPV vaccines. There's a whole toolkit for immunization and promoting it via social media. And there's lots of vaccine hesitancy resources. And here they are. Hopefully we have time for some discussion or questions. I'm happy to take what you have. Just put it in the box. Someone asked, you were saying we need a different vaccine each year due to shift, or is it antigenic drift? And as I said, it is antigenic shift, which is the movement of, drift. You're right. Did I say shift? I didn't mean to if I did. So drift is those point mutations in the influenza virus. And so that's why we need new vaccines each year. That's the variation in the neuraminidase and hemagglutinins. And those are what we're looking for 6 months prior to each vaccine season or influenza season in order to make our new vaccines. Shift is when you have a whole portion of the gene that changes, and that causes pandemic influenza. Oh, that's a great question. Okay, the question is, there's a push for childhood vaccines to be provided in drugstores now, administered by pharmacists and their technicians. Do you think this will impact vaccine hesitancy? I certainly think it will impact the ability to combat vaccine hesitancy, in that those folks don't have an established relationship with the parents and children, and probably will not have as much of an impact on convincing parents who are hesitant about vaccination in terms of educating them and maybe even changing their mind about not getting a vaccine. So I think that longitudinal relationship between a pediatrician and families is super important when it comes to combating vaccine hesitancy. Next question. We know that COVID-19 has a bad effect secondary to cytokine storm. Does the mRNA vaccine theoretically cause a cytokine storm? Did any study check cytokine markers after COVID-19 vaccines? So this is really a talk about influenza vaccination, and that's what the AAP kind of set forth. So I'm not going to comment specifically on the COVID-19 vaccine, other than that's not what has played out in the studies that in terms of that we saw significant side effects of that nature. The current vaccines are FDA approved down to age 16 in one case. Yes, there are ongoing studies, and they're enrolling now to look at younger children in terms of the COVID-19 vaccine. Oh, that's a great question. The number needed to vaccinate for influenza for pediatric patients and how this is different from studies done looking at vaccine efficacy. Is it easier for families to understand vaccine efficacy as opposed to number needed to vaccinate? So that's interesting because each year influenza virus changes. And so even the virulence and the severity of disease tends to change. As we know, some seasons are much more severe than others. And so that is a moving target. And I don't know that we really have a number needed to vaccinate per se. And that really has to do with that changing target. And it's a good question whether or not families would understand efficacy versus number needed to vaccinate, and I don't know the answer to that. Could I comment on the use of antivirals for the treatment of influenza? We use it in certain specific situations, but what is the true efficacy of those medications? And then there's, with the decline in flu in both hemispheres this year from social distancing and masking, do you anticipate a change in the effectiveness and being able to anticipate drift for 2022? That's a really good question. So the first one, the use of antivirals in influenza, there are only certain circumstances, and those are outlined in the recommendations, the 2020-2021 recommendations for influenza, which is accessible through the AAP website or through PubMed. And really, this is a talk more about hesitancy and vaccination rather than treatment. So I'm not going to get into that because I could go on for a very long time. But when it comes to the decline in flu cases, I do think it will be more challenging to really anticipate the drift for 2022 and which components of the vaccine will need to be changed. I think that remains to be seen. This is again a constantly moving target. So I don't know how that will specifically affect our vaccine choice in 2022, but I think it will. Sorry, I don't have a more specific answer to that. I think we have hit 8:30, and so if we don't have other questions, I want to thank everyone for participating and watching the talk. And certainly, I believe that these slides and resources will be available to you following the presentation, from what I understand. So with that, I hope you all have a great day, and thanks again for inviting me.